Hello, my name is Oliver. I'm a cardiac scientist working at the Royal United Hospitals Bar, which is a specialist centre for pulmonary hypertension in the UK. Today I'm going to talk you through the findings of our audit, the role of right ventricular free wall longitudinal strain in the echocardiographic screening of those with suspected pulmonary hypertension and low echocardiographic probability. Pulmonary hypertension, or PH, is a disease associated with an elevated blood pressure within the arteries of the lungs. pH is defined as a mean pulmonary artery pressure greater than 20 millimeters of mercury at rest, as assessed by right heart catheterization. Precapillary pH is differentiated from isolated postcapillary pH by pulmonary vascular resistance greater than or equal to 3 Woods units. pH etiologies are categorized into 5 clinical subgroups as depicted in Table 1, with left heart disease believed to be the most common cause of PH. If left untreated, the associated morbidity and mortality of PH is high. Transthoracic echocardiography, or TTE, is an established screening tool used in the assessment of suspected PH. Historically, a measurement of the peak tricuspid regurgitation velocity and estimated right atrial pressure has been used to estimate pulmonary artery systolic pressure. However, there is evidence to suggest Doppler TTE estimates of pulmonary artery systolic pressure are inaccurate compared to right heart catheter measurements. Therefore, both the ESC and BSE recommend a multi-parameter assessment of the TTE probability of PH. Measurements of the peak TR velocity, ventricles, pulmonary artery, IVC, and right atrial area are used to provide either a low, intermediate, or high probability of PH. This retrospective audit sought to determine the accuracy of the BSE ESC TTE probability algorithm. We also aim to assess the added predictive value of including right ventricular free wall longitudinal strain in the TTE assessment of those with suspected PH and low TTE probability. To our knowledge, no study has previously looked at the use of RV free wall longitudinal strain as a screening tool in pulmonary arterial hypertension. LV dedicated AFI speckle tracking software was used to measure RV free wall longitudinal strain with an average of the basal, mid, and apical free wall segments used to quantify strain values. A sample of 310 patients undergoing initial investigation for clinically suspected PH between 2010 and 2019 were retrospectively audited. All patients with known PH were excluded, and only those that had a right heart catheter within 4 months of TTE were included. PH-TTE probabilities were calculated following BSE ESC guidance. Any TTE measurements used in the TTE PH probability algorithm that were missing were retrospectively remeasured with the PH status blinded. A diagnosis of PH was defined as a right heart catheter mean pulmonary artery pressure greater than 20 millimeters of mercury. PH etiologies were identified using the WHO classifications of PH. The results showed that the mean interval between TTE and right heart catheter in the sample was 31 plus minus 30 days. 76% were found to have right heart catheter PH with an average mean pulmonary artery pressure of 42.8 plus minus 11.7 millimeters of mercury, with the most frequent underlying etiology being chronic thromboembolic PH or CTEPH. 53% of the sample had a high TTE PH probability, 22% had intermediate, and 25% had a low TTE probability. 96% of those with high TTE probability and 78% with an intermediate probability had PH confirmed at right heart catheter. The sensitivity and specificity for detecting PH was 89 and 68% respectively. However, 35% of low TTE probability patients had PH with an average mean pulmonary artery pressure of 31.9 plus minus 6.6 millimeters of mercury. PH secondary to left heart disease, CTEPH, pulmonary arterial hypertension, and multifactorial or unclear PH was observed in this group. The 4 pulmonary arterial hypertension patients all had PH secondary to connective tissue disease. NT-proBNP values were significantly higher in those with left heart disease. However, no significant difference was observed between those with precapillary pH and no pH. Echocardiographic parameters in those with low TT probability and pH are compared to those with low TT probability without pH in Table 3. None of the TT parameters used in the BSE-ESE algorithm were able to identify those with pH and low TT probability. RV free-wall longitudinal strain, however, was significantly lower in those with pH and low TT probability, minus 20.6 plus minus 4.1% versus 23.8 plus minus 3.9%, p less than 0.02, as seen in Figure 7. RV fractional error change was also lower in those with pH and statistically significantly lower in those with precapillary pH, 25.9 plus minus 8.7% versus 38.6 plus minus 9.7%, p less than 0.01. Moreover, those with pH also tended to have prolonged isovolumetric relaxation times, but this difference did not reach statistical significance. RV free-wall longitudinal strain was retrospectively measurable in 50% of the sample and was significantly lower in those with pH compared to those without, minus 17.4 plus minus 6.8% versus minus 24.1 plus minus 5.1%, p less than 0.01. RV free-wall longitudinal strain was significantly lower in those with a high probability compared to both intermediate and low probability groups. Those with precapillary pH tended to have lower RV free-wall longitudinal strain values compared to those with left heart disease. However, this difference was not significant. In addition to those with low TT probability, RV free-wall longitudinal strain was also lower in those with intermediate probability, as seen in Figure 10. However, this difference was not statistically significant. This may have been due to the low number of patients with no pH that had measurable RV free-wall longitudinal strain in this group. Receiver operating characteristic analysis demonstrated an area under the curve of 0.78 with 95% confidence intervals ranging from 0.71 to 0.86. Using a cutoff RV free-wall longitudinal strain of less than 23%, provided optimal sensitivity and specificity of 80 and 60% respectively. A subgroup analysis in those with pH secondary to CTEPH or connective tissue disease showed sensitivity and specificity of 83 and 60% respectively. There were 37 all-cause mortalities in those with pH during a median follow-up period of 2 years, interquartile range 1 to 3 years. RV free-wall longitudinal strain was significantly lower in those with pH that died. Other TT parameters associated with all-cause mortality included higher peak TR velocities, presence of a pericardial effusion, and TT evidence of raised right atrial pressure. ROC curve analysis was used to determine the optimal RV free-wall longitudinal strain value for predicting all-cause mortality. A cutoff value of less than or equal to minus 15.5% was used to distinguish those at high or low risk of all-cause mortality. Kaplan-Meier survival curve analysis revealed a significant difference in survival between low and high risk RV free-wall longitudinal strain scores, as seen in Figure 11. Univariate hazard ratio showed an increased risk of all-cause mortality in those with high RV free-wall longitudinal strain scores compared to low RV free-wall longitudinal strain scores. Univariate hazard ratios 4.517, 95% confidence intervals 1.454 to 14.038. In conclusion, the PHTT probability algorithm provides high sensitivity and moderate specificity for screening individuals at risk of pulmonary hypertension. However, 35% of patients with low TT probability had pH confirmed by right heart catheter. Therefore, alternative strategies are needed to improve the sensitivity to detect pH in those with low TT probability. These findings suggest that including RV free wall longitudinal strain in the TTE assessment of suspected pH not only provides important prognostic information, but may also increase the detection of pH in those with low TTE probability. Future prospective research needs to focus on identifying any contemporary TTE measures that could increase the sensitivity of detecting pH in this group. These include the assessment of right ventricular diastolic parameters, as well as right ventricular and right atrial dedicated strain. Here are my references, and thank you kindly for listening.